Good morning and welcome to all for joining us today for our International Menopause Society presentation on vasomotor epidemiology and challenges in the workplace. I'm Dr. Peter Schnatz. I'm the Associate Chairman and Residency Program Director in the Department of OBGYN at the Reading Hospital Tower Health, part of Drexel University. I'm also co-chairman of the Educational Committee at the International Menopause Society. Wendy, would you like to introduce yourself to our guests, my co-moderator here?
Thanks a lot, Peter. I'm Wendy Wolfman. I'm a professor in the Department of Obstetrics and Gynecology at the University of Toronto and director of the Menopause and Premature Ovarian Insufficiency Clinic at Mount Sinai Hospital in Toronto. I also am a co-head of the Educational Committee for the International Menopause Society with Peter, and it gives me great pleasure to present an amazing webinar today on vasomotor epidemiology and challenges in the workplace with Peter.
Wonderful. Thanks, Wendy. And we are honored to be the panelists, the moderators today to help guide us through a wonderful presentation. We have Dr. Rebecca Thurston, Rossella Nappi, and Petra Stute, whom we will be introducing prior to each of their presentations. But we would like to give a wonderful thanks and appreciation today to Astellas for allowing us to bring this presentation to you. If you go to the next slide, we will give them the appreciation that we'd like to acknowledge Astellas as our sponsor, but also very importantly to point out that they had no role in the selection of the topics or the speakers, and they have not vetted or reviewed any of the content of the speaker presentations, as this is an unbiased presentation that is sponsored for the educational content. So thank you to them. Next slide. Okay. Wendy, would you like to take us away and introduce our first presentation?
So I'm thrilled to present Professor Rebecca Thurston. She's the Pittsburgh Foundation Chair of Women's Health and Dementia, Professor of Psychiatry, Psychology, Epidemiology, and Clinical and Translational Science, and Director of the Women's Biobehavioral Health Program at the University of Pittsburgh. She's an expert in the menopause transition and its implications for women's cardiovascular and brain health. She's the principal investigator of the MS Heart and MS Brain 1 and 2 studies. Dr. Thurston is also a principal investigator of the study of women's health across the nation, and she's an elected fellow of the American Psychosomatic Society and Academy of Behavioral Medicine Research and past president of the Menopause Society. And I thank her also for bringing menopause into a validated physiological symptom by her research, which I really think is innovative and strong. So thank you very much, Rebecca, and we're looking forward to your talk today.
Thank you so much for that kind introduction, and I'm very pleased to be speaking with you all today. Let's do a little share screen here. Okay, all right. So I will be talking to you today about vasomotor symptoms, epidemiology, pathophysiology, and implications for health. This work is funded by the National Institutes of Health, and here are my disclosures. So some of the data that I'll be presenting to you today comes from the Study of Women's Health Across the Nation, or SWAN. And SWAN is a large longitudinal cohort study of the menopause transition conducted at 7 sites around the United States and 5 different racial ethnic groups. SWAN began in the mid-1990s, and we have conducted visits subsequently, and we just actually finished up our 18th follow-up visit. All the women were pre or perimenopausal at baseline, and they have been followed through the menopause transition. Another study I'll be talking to you today about is this Ms. Hart study. This is a study of 300 peri and postmenopausal women. And what's unique about the Ms. Hart study, it was conducted here in Pittsburgh. All of the women underwent physiologic hot flash monitoring. So here we're able to look at how physiologic hot flashes relate to women's cardiovascular health. And the next generation of Ms. Hart was Ms. Brain to women's brain health. So let's get started. So vasomotor symptoms collectively are known as hot flashes or hot flushes and night sweats. Upwards of 70% of women experience hot flashes or vasomotor symptoms during the menopause transition. And for a third of women, they're very frequent or severe. And we used to think these lasted maybe 3 to 5 years around the final menstrual period. We now know that they last more like 7 to 10 years for frequent or moderate to severe hot flashes, and for milder hot flashes, even longer. Swan has shown us here in the United States, at least, that we have pronounced racial ethnic differences in hot flashes. The African-American women, upwards of 75% of African-American women get hot flash in the US. About half of the Asian women living in the United States get hot flashes, and the white and the Latinas are in the middle. And they peak when you consider the average over the population in those years right before and after the final menstrual period. However, there also is dramatic variability in the patterns of hot flashes that women will follow. So here on the x-axis, we have years around the final menstrual period. This is how we measure one measure of reproductive or ovarian aging. That time 0 is the onset of the last menstrual period before 12 months of amenorrhea. That's our demarcation of the postmenopause. And what you can see is that the women in the green have their vasomotor symptoms primarily pre or early perimenopausally. We have the women in the purple who have their vasomotor symptoms primarily postmenopausally. We have the women in the blue who have a little bit of hot flashes right around that final menstrual period, but otherwise relatively spared. And then we have the women in the red. And these women start early and they just keep going. And that is about a quarter of the population of SWAN. So really, there's a lot of variability in the patterns that women will follow. And this was picked up by the New York Times here, a major newspaper in the United States, because it really challenged these notions of hot flashes as these benign, short, benign symptoms that happen just for a couple years. They actually, for many women, go on and on. So what are the risk factors for vasomotor symptoms? Women with lower educational level, higher baseline levels of anxiety or depressive symptoms premenopausally go on to have more vasomotor symptoms, a higher BMI, but an asterisk around that. I'll get a little bit more nuanced about adiposity. Smoking and more premenstrual symptoms were predictors of more vasomotor symptoms in SWAN. We also found that women with a history of child abuse have significantly elevated hot flash reporting as well as night sweat reporting over the course of the menopause transition, with an adjusted odds ratio of about 1.7. And in fact, when in the Ms. Hart study, where we use physiologically assessed hot flashes, we also see this association for objectively monitored hot flashes, that women with a childhood history of sexual abuse or physical abuse have more physiologically detected vasomotor symptoms, primarily at night. So we do see this both with our objective and subjective measures of hot flashes. So what is the physiology of vasomotor symptoms? We know that these hormonal changes of the menopause transition, so those declines in ovarian estradiol in the red and increases in follicle stimulating hormone in the blue, these two hormonal patterns, classic menopausal patterns, are associated with increased hot flash reporting. But really, all women have these hormonal changes. Not all women have hot flashes. There's clearly more going on. This is our classical heuristic about hot flashes that has involvement of the thermoregulatory system of the brain and the body. And it goes something like this. Our core body temperature is maintained within a fairly narrow thermoneutral zone of about 0.4 degrees C. And sweating is one way that we dissipate heat when our core body temperature goes above this zone. And shivering is a way that we conserve heat when our core body temperature drops below this zone. And there's some data to suggest that this zone is very narrow in menopausal women, such that small perturbations in core body temperature may trigger these thermoregulatory mechanisms, such as sweating or shivering. Now, more recently, Naomi Rance and colleagues have elucidated the underlying hypothalamic neurobiology of vasomotor symptoms, and she isolated the neurokinin B receptor, KNDy neurons here in the medial basal hypothalamus. And these KNDy neurons, these really represent this kind of relay station between our GnRH pulse generator, our master controller of the reproductive axis in women, and those thermoregulatory centers in the brain, which also reside within the medial basal hypothalamus. And our new class of agents, these neurokinin 3 receptor antagonists, act at this neurobiology, at these KNDy neurons, which become hypertrophic during, given the release of ovarian estradiol control here, and really functions to dampen those down and have shown to be quite effective in reducing the onset of vasomotor symptoms. So we have our new class of agents working at this understanding now that we have of the neurobiology of hot flashes. So I mentioned that there is complex relationships between obesity and vasomotor symptoms. So we used to think that adipose tissue was protective against vasomotor symptoms. We now know that that is actually, it's a much more complex story. We have found in SWAN that women with higher body fat actually have more reporting of vasomotor symptoms. So this sort of dose response association here, and specifically also when we're measuring body fat, not just body weight. And that fat gains over the course of midlife actually increase the odds of subsequent reporting of vasomotor symptoms. However, there's interactions by menopause stage here, such that the effect of adipose tissue or obesity as being associated with more vasomotor symptom reporting is actually only occurring in the pre and early perimenopausal years. And during the late peri and postmenopausal years, you either get null or inverse associations. So really, the idea here is that when women are early in the transition, that higher adipose tissue is going to increase the likelihood of having vasomotor symptoms, potentially due to a dampening effect on ovarian function due to inflammatory mechanisms. And then once the ovary has stopped, that body fat really represents your sole source of estrogen. So it actually may be a little protective. However, it's even more complicated because we now know these are data from SWAN as well. This is work conducted by Carrie Gibson, showing that increases in vasomotor symptom occurrence over time are also associated with increases in weight at subsequent visits. So really this relationship between adiposity and vasomotor symptoms is both bidirectional, and it depends on where a woman is in the menopause transition, the really impact that this adipose tissue is having. Okay, so what else is going on? What are the consequences of vasomotor symptoms? Let's talk about sleep. Sleep is a major issue for midlife women. Upwards of 50% of women will report problems with sleep over the course of the menopause transition. And we know that these women who have more vasomotor symptoms, these are frequent vasomotor symptoms here at SWAN, these women will have a 5-fold increased odds of having sleep problems, whether it's trouble falling asleep, waking up several times a night, or waking up early. And even those women, however, with low frequency vasomotor symptoms, so this is less than every other day, those women will have a doubling of the odds of sleep problems. So really, there's quite a relationship here between hot flashes and sleep. These are all self-report data. This is data from SWAN. So in order to use objective measures of both sleep and hot flashes, we moved to our Ms. Hart study. And here we conducted a time series analysis where we're seeing about whether hot flashes are actually associated with acute awakenings. And what we see is indeed that's the case. So you have a substantially increased risk of an awakening right around that physiologically assessed hot flashes as compared to the periods preceding or even following the hot flash. And this does not matter whether a woman reported the hot flash or felt the hot flash. We did see an awakening, even if she thought that she was sleeping through it or didn't know that she was having it. And in fact, we saw a little bit here that the awakening actually preceded the peak onset of hot flashes, which many women have told me occurs. What else is going on? We know that mood and anxiety issues are major issues for midlife women. And we see here that anxiety in particular is associated with vasomotor symptom reporting. So these are SWAN data showing an increased odds of reporting anxiety, elevated anxiety symptoms, particularly in that late perimenopausal period. And then the green bars here indicate the models adjusted for vasomotor symptoms. So indicating here that the vasomotor symptoms occurrence is accounting for much of this increased likelihood of reporting anxiety over the course of the menopause transition, with a little bit of a residual effect here in the early perimenopause. So when you see that increases in anxiety during the menopausal symptoms, that is in part driven by the occurrence of vasomotor symptoms. These are data from the daily hormone study in SWAN, where we had women carrying around daily diaries, and they were reporting both their hot flashes and their moods. And what we really wanted to disentangle was the relationship between negative affect and vasomotor symptoms. What directionality was this going in? Was the negative affect driving the vasomotor symptoms, or were the vasomotor symptoms driving the negative affect? Because we know negative affect is a risk factor for reporting hot flashes over the course of the menopause transition. What we found was that controlling for same-day negative affect, we really saw that the vasomotor symptoms were driving the negative affect, and this was partly because of sleep problems. And this is our classic domino hypothesis, where those hot flashes are driving the sleep problems, which are driving the negative affect. So again, this is not the only pattern that women follow, but this was the predominant pattern that we saw in the daily hormone study. However, we also know that that negative affect really impacts how women experience their vasomotor symptoms. So here we're looking at what predicts the bother associated with vasomotor symptoms over and above the frequency at which they occur. And I want to direct your attention to that first line. We see that negative affect really increases the likelihood of experiencing those hot flashes that are bothersome, controlling for the frequency of hot flashes. And we see in the bottom line here that those sleep problems are also increasing the likelihood of experiencing night sweats as bothersome, controlling for the frequency of those night sweats. So really the negative affect is making it really difficult to cope with these symptoms. And that's where our cognitive behavioral treatments for vasomotor symptoms are coming in. They're really helping us make these more manageable by going after this negative affect and these appraisal mechanisms. So what are the correlates and consequences of vasomotor symptoms? We've looked at cardiovascular health. Here we're using vascular imaging modalities to understand the health of the vasculature among midlife women before clinical cardiovascular disease is present. Because women tend to get their heart attacks and strokes much later in life. At midlife, we're measuring the vasculature directly before they have disease. And what we saw was that women with more hot flashes have poor endothelial function, as shown by lower flow media dilation here. This is a measure of the inner layer lining the vessel, very important to vascular tone and health. And basically, the more hot flashes she has, her poorer her endothelial function. This is not explained by cardiovascular disease risk factors or hormone use or endogenous estradiol. We also see that the more hot flashes a woman has, the higher her carotid intima media thickness, a measure of carotid atherosclerosis in a dose-response fashion. This is self-reported hot flashes. In Ms. Hart, when we're using objective hot flashes, we also see the more hot flashes a woman has, the higher her IMT, as well as higher her carotid plaque. And also going back to SWAN, where we actually have cardiovascular disease events, women with more hot flashes have 50% increased risk of having a heart attack or stroke over the subsequent 20 years. And this is particularly pronounced if a woman is having persistent vasomotor symptoms over the course of the menopause transition. So we see these links between hot flashes and cardiovascular disease. We also see links with brain health. This is work by Pauline Mackey showing that more hot flashes are associated with poor verbal memory performance over the course of the menopause transition. We have also done neuroimaging with white matter hyperintensities of the brain. These are markers of small vessel disease in the brain. So do we see in the peripheral vasculature? Do we see the same thing in the cerebral vasculature? And the answer is yes. This was a pilot study in 20 women. So pilot work here showing work with more physiologically assessed vasomotor symptoms at night, more white matter hyperintensities in the brain, these markers of small vessel disease. Also, greater hippocampal default mode network connectivity. But most importantly, in the Ms. Brain study, where we have a much bigger sample of women, we saw the same thing. The more hot flashes you had, the higher your white matter hyperintensities in the brain. So really validating this across multiple different study samples. In small samples, large samples, we see the same thing. And also we see more hot flashes associated with objectively assessed hot flashes with lower A beta 4240, a marker of circulating amyloid. This is part of the pathophysiology of Alzheimer's disease. Okay, so I'm going to go through this pretty quickly to save some time. Just a couple mechanisms. The more hot flashes you have, we also see higher circulating CRP in Ms. Hart. This is work conducted by Mary Carson. CRP being an important inflammatory marker associated with increased risk for cardiovascular disease, also brain aging. We see also a less anti-inflammatory markers, so adiponectin is lower when you have more physiologically assessed vasomotor symptoms. We also see heart rate variability, withdrawal during hot flashes, showing that parasympathetic withdrawal. This is a cardiotoxic profile. And then finally, we see increases in cortisol associated with hot flashes, sort of a subtle effect here, but these are a couple different studies where you see some alterations in cortisol slopes over the course of the day. So these are some potential underlying mechanisms. Finally, we see some accelerated epigenetic aging with more persistent vasomotor symptoms as well. So in summary, vasomotor symptoms are prevalent and persistent. There's a really important interplay between thermoregulatory and hormonal mechanisms at the level of the medial basal hypothalamus. Risk factors for hot flashes span sociodemographic, psychological, as well as biological risk factors. And these vasomotor symptoms have implications for women's mood, sleep, cardiovascular, and brain health. And we do all of this work, of course, to improve women's health. Thanks to the study team and our study participants, among whom none of this would be possible.
There we go. Fantastic. Really appreciate your outstanding presentation. We will move now to our second presentation by Professor Rossella Nappi. She's going to be speaking on hormonal management of vasomotor symptoms. She is the full professor of obstetrics and gynecology in the Department of Clinical, Surgical, Diagnostic and Pediatric Sciences at the University of Pavia. She's a gynecologist, endocrinologist, and sexologist. Her major interests are in the field of psychoneuroendocrinology of the female reproductive and post-reproductive life, with a special focus on women's sexual health. And at present, she is a permanent member of the advisory board of the International Society of Gynecological Endocrinology, or the ISGE, and she's the president-elect of the International Menopause Society. Rossella, welcome, and we look forward to your presentation.
Thank you, dear moderator. Thank you for inviting me today. And following the fantastic lecture from Rebecca, I think everybody has understood how it's important to effectively manage vasomotor symptoms. And my job today is really to revise the reason why all the guidelines in the world, including the IMS, but I selected the last one from the American Menopause Society, now with a new name, the Menopause Society, because it's the most recent. And of course, everybody knows this statement. Hormone therapy remains the gold standard for relief of vasomotor symptoms. And this is the main indication in order to improve several domains of quality of life of women. And another very important point that is the focus of what I will show you today, because we have this statement out there and we do not remember so much about all the different products that we have in our hands, depending on formulation, doses, and route of administration. And therefore, it's very important to revise to everybody that we have a full range of options in order to individualize the treatment and to ensure that every woman will be treated effectively for vasomotor syndrome. I would like to start with this very interesting systematic review that was published by Heidi Nelson around 20 years ago. So these are information that are very out there in the literature since so many years. But at that time, as you can remember, it was immediately after the WHI. So it was extremely important to understand the issue of the dose, because you remember that at the standard dose with conjugated estrogen 0.625 plus medroxyprogesterone acetate, there were some risk for women's health, and so all the world was shocked by that notion. And what it comes out from this systematic review? First of all, the review confirmed what we know already, that conjugated equine estrogen and oral intradermal 17-beta estradiol were more effective than placebo in relieving menopausal hot flashes. And this is important to remember to everybody because, as you know, placebo effect is quite strong for this kind of symptoms, especially if we measure them subjectively. The second point of this review was to pointing that we had a range of doses, and a range of doses is effective. Although not so many signals in the literature pointed on a dose response. So that was important to investigate it even more in order to propose to women, following 2004, the lowest effective dose. And I will show you some data. And another interesting point of this review was that also, although data were limited, the concomitant use of progestin or progesterone did not influence the positive effect of estrogen. And very recently, we are even discussing if some progestogen, especially micronized progesterone, can further improve, for example, the positive effect of estrogen on night sweat or sleep. Another very interesting point was that the use of conjugated equine estrogen and oral intradermal 17-beta estradiol had consistent and comparable effects on treatment of hot flashes. And this is very, very important because, as you know very well, the data in the WHI were produced with conjugated equine estrogen, and at that time it was very important to think about new option, and so using the so-called identical hormone to those of the woman body, so natural estradiol. And this is a cartoon I remember very much from an old North American Menopause Society. This was Professor Notevelovitz that so many years ago was able to show that estradiol alone and the dose was very important, but we can observe a positive effect against placebo even with lower doses. So you can go down to 0.5 milligram of oral micronized estradiol, and you can still significantly reduce moderate and severe hot flashes in menopausal women. But for sure, an intermediate dose of 1 milligram appears in a risk-benefit balance, the most useful initial dose. And so this is nowadays the best oral estradiol dose we can propose to our patient in order to relieve hot flashes in the majority of women. And this is still true. You see, for example, from the graph on the right, let me see if I'm able to show you, that a significant percentage of women report at least a 90% reduction in hot flashes weekly when was on the standard dose. We know at the very beginning that was 2 milligrams, and even with 1 milligram. At the same time, more or less, we were studying also the transdermal route of administration. Estradiol, as you know very well, can be used also with patches, and these are the seminal papers that were published so many years ago by Wolf-Eugen, in which he showed that all the three dosage of transdermal estradiol, you see, starting from the high dose 100, the intermediate standard dose 50, that is the dose I started my career in 99, because remember that in Italy we were using, and in Europe in general, in France especially, we were using a lot of natural estradiol since the very beginning, but also the lower dose of 25 microgram, they were extremely effective in the usual design against placebo 12 week in reducing the number of moderate or severe hot flashes, and there was a high rate of responders with both doses, the 50 and even the 25. So this is the reason why that was the standard. Later on, we have in the literature many other studies. I select this one by Professor Archer in 2012, in which we observed that also a gel, so a product that you put every day and not with a patch on your skin, you are able to reduce significantly the frequency and the severity of hot flashes. And this is also dose dependent. So we have some data more recently in comparison to the systematic review I showed you in 2004, that you have a dose dependent effect, and depending on your patient you can really individualize the treatment. And this treatment in gel, they are quite well tolerated, and French people, they know very well because they use since so many years. And there is a high rate, you see, more or less 60-70% of response with the standard dose we use, 0.375, of reducing at least 50% from baseline moderate to severe hot flashes. Another study that was out there in the literature, and that is interesting in my view, because it's a way to highlight the power of estradiol for women's health, is the study that was published by Gloria Bachman on the microdose of 0.01. We know that this is a dose that is able at least to preserve the bone mineral density, but is not so effective in relieving hot flashes, because as you can see, there is a good number of women, they respond. There is a significant separation against placebo, but the rate of responder is not so high. But this data highlight, in my view, the fact that the drug is really powerful, even a very low dose. And therefore, we have always to think about that in women, they may be at higher risk for using systemic estradiol, even though if we prescribe transdermal, you may offer some release, or also with very little dose of estradiol. Another interesting point is the combination with progestins, and I select all the progestin that were available just to reinforce this idea that, of course, we know that progestin is so important for endometrial protection, but the progestin is not able to antagonize, because we know that progestin antagonizes the activity of estrogen on the endometrium, and this is very useful for endometrial protection in safety study conducted up to 52 weeks, but is not able at all to antagonize the good effect of estradiol on hot flashes. This is a patch that we have used a lot in Europe. That is a combination of 70-beta estradiol with levonorgestrel, a very important progestogen that we use so much in contraception. And you see that different doses in combination, they are equally effective in reducing hot flashes frequency and also severity. And this is interesting because it's a confirmation that you may individualize not only the estradiol dose, but you may individualize also the dose of progestogen. Unfortunately, these patches, they were not so well available across the world because, as you know very well, the market following WHI was so little that companies maybe they did not market all the product they have studied so far in research center. This is a data also I like very much because we have some experience in Europe with this very little low dose of oral estradiol with another progestogen that is norethistron acetate, and you see that in this paper by Nick Panay, our actual president of IMS, you may observe a significant decline of hot flashes frequency in comparison to placebo. And even a very, very little dose of norethistron acetate, I may assure you, is capable to protect the endometrium. I'm not showing you this data, but just to remind to everybody that with little dose of estradiol combined to little dose of progestogen, we may really make the life of women differently. And here the same concept also with another progestogen that we have used so much in Europe and across the world, that is dihydrogesterone. Dihydrogesterone is very, very similar to natural micronized progesterone. And you see in this paper by John Stevenson, the 0.5 milligram of estradiol combined also with a low dose 2.5 of dihydrogesterone in comparison to the standard combined dose that we use 1 milligram and 5 milligram is absolutely able to reduce significantly the number of moderate and severe hot flashes to week 13, and this is capable to improve quality of life as well. And last, information on the different types of progestins, synthetic progesterone, is another compound that we have used very much, especially in Europe. The European Society of Cardiology have studied very much with the menopause expert, because drospirenone, as you probably know very well from the data we have on contraception, is a progestin very special that is a derivative of spironolactone, so has a mild but significantly ability to reduce blood pressure and also to antagonize the adiposity in the female body. So has been studied quite a bit for women carrying not only hot flashes but also some kind of cardiovascular risk, but unfortunately was launched really in 2002, and therefore then we didn't go on with this kind of research very much. But you see that also a very, very little dose, 0.5, that is half the dose that was on the European market since the very beginning, you are able to significantly reduce hot flashes in terms of frequency and also severity. Just a little word on a very old compound that made the history of, and is still on the market, of course, and is so widely used, that is conjugated equine estrogen. This is a seminal manuscript that was published by Ulf Euthen, in which he was able to show very clearly to the world that even though when you cut the dose, so you move to 0.3, or when you are in the middle with 0.45 milligram of conjugated equine estrogen, you can be able to significantly reduce effectively the number of hot flashes against the placebo and also the severity. And you can do that by using conjugated equine estrogen alone or combining with medroxyprogesterone acetate at different dosages, even very, very low dose. More recently, as you know very well, there is this new age to use natural estradiol and natural micronized progesterone because of all the data we collected in terms of safety on other target tissue, for example, the breast, for example, the heart, etc. And as a secondary endpoint of this longitudinal study, the so-called KIPS, the Kronos Early Estrogen Prevention Study, you see very clearly that hot flashes and night sweat, but also the other symptoms of the domino effect that Rebecca was alluding to, for example, insomnia, is significantly reduced over time. And keep in mind, this is a study 4 years long. And the effect of transdermal estradiol in comparison to an intermediate dose of conjugated equine estrogen is almost equal, is quite fast, and is effective over time. So it's very interesting to point that natural estradiol and natural progesterone can be as good as all the products we had in the past. And probably this is the reason why more recently on the US market approved by the FDA and even in Europe, we have a combination oral that is for sure convenient because in one tablet women, they take the right amount of estradiol, micronized estradiol and micronized progesterone in one capsule, 1 milligram and 100 milligram dose. And this is a drug that has been studied as safe in a very rigorous trial. And you see that even lower dose of the drug are capable of reducing the frequency, less capable to reduce the severity. And this is the reason why, against placebo, we have on the market 1 milligram and 100 progesterone, micronized progesterone. And just to conclude, two products we have, they are quite special and they are on the market to relieve vasomotor symptoms effectively. One is the concept of the TSEC. I select this analysis just to show you that this product is effective in women, not only during the immediate postmenopausal, perimenopausal and immediate postmenopause, but also overall over time, even in women, they are treated 5 years and more. This is a series of studies that were named SMART studies, so selective estrogen menopause and response to therapy. And you see the change from baseline in frequency and severity of moderated to severe hot flashes at month 3. And the combination of even an intermediate dose, that is the one we have on the market, combined with the SERM basedoxifene, and this is as an indication exactly like a traditional menopause hormone therapy, so for the relief of hot flashes and even to prevent postmenopausal osteoporosis, show to be extremely effective. And this is one of the things that are most novel in the field of menopause hormone therapy. And last product I want to show to the audience is a product that was there when I graduated in 1999 in Europe and even across the world. I know that is widely used in Latin America and Central America, even in Asia. That is a Tibolone. Tibolone is a special kind of product that we may define as STEER, a selective tissue estrogen receptor modulator with a variety of activity in the female body. And you see that the standard dose we have on the market since so many years, not in the US, unfortunately, and I think even in Canada you don't have, but also the half dose that was available in Switzerland, for example. But unfortunately, even this dose was launched at the time of WHI and then was not marketed in other countries, was able to effectively relieve hot flashes against placebo across the 12-week we usually investigate against placebo. So, dear friend, I hope I have convinced you that hormonal replacement therapy with estradiol and any kind of progestin at every dose we propose, standard, but also low dose, they are much more effective against placebo, but also against a wide range of products we have on the market. They are prescribed to women out of the real indication. Think about SSRI, SNRI, gabapentin, etc., and also against other natural products. They are much less effective. And we hope that in the future, with this new drug that Petra we presented to you, we can fill the gap of what we know about our patient. Because you see this cartoon for one of my recent survey suggests that there are still a lot of women that don't use menopause hormone therapy, not only because they have contraindication, but because they are averse, we are afraid, etc., etc. And so thank you very much for your attention.
Thanks a lot, Rossella, for that wonderful presentation and overview. It's really good to review also older information. I think we should recognize that work that was done by the people who came before us. So now it gives me great pleasure to present Professor Petra Stute, who will be speaking on non-hormonal management of vasomotor symptoms. She's a Deputy Director of Gynecologic Endocrinology and Reproductive Medicine, Director of the Menopause Center, Department of Obstetrics and Gynecology for the hospital in Bern. She's the leading physician, Leighton Ertzen, Gynecological Endocrinology and Reproductive Medicine, Department of Obstetrics and Gynecology in the hospital in Bern, Switzerland. Sorry about my accent. So I look forward to your talk, Petra.
Thank you very much. Okay, so it's a great pleasure for me to talk about the non-hormonal management of vasomotor symptoms now. This is my conflict of interest. And as Rossella already mentioned, I'm going to talk about FIOSA or fasolinetant. And it's important to recognize that the FDA, EMA, and Swissmedic regulations differ slightly. So my basis is going to be, of this presentation, is going to be the EMA approval. And as we wanted also to talk about women in the workplace, I was wondering which woman I could choose who is really working hard and who is feeling hot all the time. And I also wanted to entertain you a little bit. Okay, so that's the woman I found. So maybe who does not know her, so she's a human Cree hybrid. So she's very, very strong, and she can, like all other women of us can work without any rest because she has a special ability with energy. And that's why she's very, very used to feel very, very hot, as we can see on this picture. So although she has self-healing powers, her human part goes through menopause, and that's why she's suffering from very severe vasomotor symptoms at the moment, and that has a negative impact on her work. And the ones of you who know her, as I already said, she is a human Cree hybrid. So before she became this hybrid, she was a human and she suffered from a venous thromboembolism. And thus she's afraid to take MHT, but she needs immediate vasomotor symptom relief. Okay, what can we offer? So we can have a look at the NAMS position paper from last year and have a look what NAMS recommends. So there are tons of strategies that are not recommended, including a lot of herbal products, but actually there are some recommended strategies against vasomotor symptoms. So let's offer them to Captain Marvel. What about weight loss? Well, she has a normal body weight, so that's probably not the best idea. And anyway, this would take too much time. So then what about cognitive behavioral therapy and clinical hypnosis? Well, theoretically, that would be also a good idea for her, but as she has to be awake all the time because she has to work all the time, that's not an option for her at the moment. So what about then SSRIs, gabapentin, and oxybutynin? Well, at the moment, as we already said, she has a lot of work to do and she has to stay awake all the time. So any medication which could make her tired is not an option at the moment. So what about then stellate ganglion block? Well, theoretically, that would maybe a good idea, but in space, there's no expert to perform this procedure. So what about fasolinetant then? And she's very much interested in that, and she wants to know more details about this drug. So that's why we are going to offer her a few more information about this drug. So fasolinetant was approved by the FDA, EMA, and Swissmedic last year. And the EMA indication is treatment of moderate to severe vasomotor symptoms associated with menopause. And there are several studies that have led to approval of fezolinetant, and these studies are called Skylight 1, 2, and 4. And I will give you a short overview about these 3 studies in just a second. And the other 2 studies, Moonlight 1 and 3, are still ongoing studies in Asian countries. So Skylight 1 and 2, these are identical studies. So women were randomized to either receive placebo, fezolinetant 30 milligram, or fezolinetant 45 milligram. And after 12 weeks of treatment, the women that had received placebo were now re-randomized to either fezolinetant 30 milligram or 45 milligram. And the overall duration of intervention was 1 year, followed by a short follow-up duration. So the Skylight 4 study it was all about safety. So again, women were randomized to either placebo, fezolinetant 30 milligram, or fezolinetant 45 milligram. And these women were treated overall for 1 year, and afterwards a short follow-up followed. And here, as I already said, the primary endpoints were all about safety. So adverse events were analyzed and also endometrial health safety. And I can make this very short, so there was no adverse impact on endometrial tissue. Okay, so our Captain Marvel is not completely convinced, and she has tons of questions that we have to answer now. So the first one is, how effective is fezolinetant in reducing the frequency of hot flushes? How quickly will I notice that Vesomotor is working? And how likely is it that Vesomotor will work for me? And how long can I take it? And let's start with the first question. So how well does Vesomotor work in terms of frequency of hot flushes? So in these 2 graphs, you can see the results for fezolinetant 30 and 45 milligram, but the dosage that has been approved is 45 milligram. So what we can see here is that after 4 weeks of treatment, hot flush frequency was reduced by 55% in comparison to 30% in those women treated with placebo. After 12 weeks of treatment, fezolinetant had reduced vasomotor frequency by 64% versus placebo 35%. And the same applied for VMS intensity. Next question, how quickly will I notice that Vesomotor is working for me? So here are the good news. Most likely our patient is going to realize very quickly that the new drug is working for her. So most likely after 1 week of treatment, she will already feel a difference. How likely is it that fezolinetant will specifically work for her? So in this case, we have a look at the percentages of participants with at least 50% of reduction of VMS frequency or at least 25% reduction of VMS frequency. And based on these results, we can answer that it's quite likely that fezolinetant will work for her, as the number of vasomotor symptoms reduced by at least 50%. This will happen in almost 60% of women after 12 weeks of treatment. How long can I take it? Well, as the studies that led to approval only took 1 year, we only can say at the moment that the data out there is only available for 1 year of treatment duration. So we have to, if we want to take it for a longer time or want to prescribe it for a longer time, then we have to assess the benefits and long-term treatment periodically. And since, as we all know, and what Rebecca already said, VMS duration can vary from women to women. So she has more questions. What about side effects? And she has read a lot about liver enzymes. So if they increase, how long will this be increased and how quickly will they go down again? And what are the contraindications? What about tumor risk? And how effective is fezolinetant in comparison to other non-hormonal drugs or MHT? Okay, let's have a look at these questions. The side effects or common side effects, there are only a few in the leaflet. So it's insomnia, it's diarrhea, it's abdominal pain, and it's also liver enzyme increase. And that's why, for example, in the US and in Switzerland, we have to check liver enzymes before we start the treatment and also after we have initiated the treatment. But for example, in the European country, it's not necessary at all to check for liver enzymes. That's quite interesting. But let's say we live in the US or we live in Switzerland, and here we have to analyze the liver enzymes. So what happens if they increase? Will they go down again on their own? And if so, how quickly? Here's the answer. So the liver enzyme elevations were generally asymptomatic and intermittent in the studies that led to approval of the drug, and usually return to baseline during treatment or shortly after discontinuation. And none of those affected fulfilled Hy's law, which means that there was never an indication for a real liver cell injury. And in the Vasolan 45 milligram group, the liver enzymes were reduced within about 1 month if they were increased more than 3 times the upper limit of norm. And this doesn't matter if the treatment was discontinued or continued. So what are the contraindications? There are only a few, but again, it's important to have a look at the leaflet or insert, a package insert, depending on where you live. But in general, there's a contraindication for co-medication with moderate or strong CYP-A1/2 inhibitors. In Switzerland, we also have a contraindication for mild CYP-A1/2 inhibitors. So we really have to double check the co-medication. And apart from that, it's hypersensitivity to the drug's ingredient or pregnancy. What about the tumor risk? So in Skylight 1 and 2, and also in Skylight 4, tumors, benign tumors or malignant tumors were assessed. And here in Skylight 1 and 2, there were 2 tumors in each Skylight study. So 2 in Skylight 1 and 2 in Skylight 2. As there's no placebo arm for the whole year, because as you remember, the placebo arm was stopped after 12 weeks, we have no data to compare this to placebo in Skylight 1 and 2. In Skylight 4, which took 1 complete year, here we have placebo data. And in the fezolinetant group, there were 14 tumors. But tumor doesn't automatically mean that it's a malignant tumor. So overall, we have 18 patients in whom 23 tumors were diagnosed during this 1 year of therapy. And of the 23 tumors, 12 were a malignancy. And you can see they were very heterogeneous. So there was breast cancer, lung cancer, skin cancer. So it's not really easy to, or we cannot just say, well, it's always this or always that. But still, these findings were a reason for a research group to do a meta-analysis of the Skylight program. And they used a special statistical method, and they thought that the tumor risk was increased. However, the evaluation has several weaknesses, and of course, Skylight 1, 2, and 4 were not powered to analyze tumor risk. So the overall, the current non-clinical and clinical data do not indicate an increased risk of neoplasms. And accordingly, the FDA concluded that this brings the incidence rate of malignancy within the normal background rate of cancer, which we would have to expect in this age group. Okay, now we come to the last question of our very famous patient. How effective is fezolinetant in comparison to non-hormonal drugs and MHT? So in January this year, a systematic review and network meta-analysis was published. And the goal of this meta-analysis was to compare phenylalanine 45 milligram to MHT and non-hormonal treatment options against vasomotor symptoms. So obviously there are no head-to-head comparisons so far around. So this is why this special network meta-analysis was performed. So all phase 3 and 4 RCTs in postmenopausal women with presenting with at least 7 moderate or severe VMS per day, or at least 50 VMS per week were included for this meta-analysis. And the endpoints were mean change in frequency and mean change in severity of moderate to severe vasomotor symptoms from baseline to week 12, and also the proportion of women with at least 75% reduction in VMS frequency at week 12. So we have, the authors found several studies and included them. So obviously Skylight 1 and 2 were included, but also 23 other comparative studies. I also show you the results for the mean change in frequency of moderate to severe vasomotor symptoms from baseline to week 12. And the first result was that most pharmacotherapies reduce vasomotor frequency significantly more than placebo. Well, that's what we expected anyway, but it's good to read it. And that phenylalanine is as effective as most MHT that were used in those comparative studies. And phenylalanine was significantly more effective than most antidepressants and anticonvulsants that were used in those studies included. So my summary. There are several non-hormonal treatment options for vasomotor symptoms available, and the following have been recommended by NAMS, or now TMS, which is weight loss, clinical hypnosis, cognitive behavioral therapy, antidepressants, gabapentin, oxybutynin, phenylalanine, and ganglion stellate block. Phenylalanine is an NK3 receptor antagonist. It was approved by the FDA, EMA, and Swissmedic last year. And in 24, just recently, a systematic review and network meta-analysis reported that phenylalanine was more effective in reducing VMS when compared to many antidepressants and anticonvulsants, and comparable to some MHT formulations. So thank you very much. And now I'm looking forward to your questions.
Wonderful. Thank you for outstanding presentations from everybody. It was really fantastic. We don't have a huge amount of time, but we have some time left here for some questions, and Dr. Wolfman and I will help guide us through these. The first one here is a question that asks whether there may be a link between vasomotor symptoms and cardiovascular outcomes, and whether it's mitigated when hormonal therapy is given. Whether acknowledging the link and then asking whether it's could be mitigated with the hormonal therapy.
Yes. We don't know that yet, so that study has not been conducted. However, I will say this: what motivated our even looking at the relationships between vasomotor symptoms and cardiovascular disease risk were some post hoc analyses from the Women's Health Initiative that indicated that this potentially increased cardiovascular risk associated with hormone therapy was most pronounced among the older women with vasomotor symptoms. So just that's the only trial data that we have. We do not have other trial data. We don't know necessarily what happens among younger women. But we do see increases in atherosclerosis among those women with a lot of vasomotor symptoms. So it's something to be cautious about. The bottom line is we don't know. There's a little bit more data with the cognitive outcomes indicating that if you treat the vasomotor symptoms with stellate ganglion blocks, specifically, that's the only intervention that's been tested, the degree of improvement in vasomotor symptoms directly corresponds to the degree of improvement in verbal memory performance. So there's a little bit more trial data there, but nothing with hormone therapy.
Yeah, I was going to ask a similar question, that how do you interpret the findings from the WHI showing more cardiovascular risk after 5 years you said it was mainly driven by the older women. In the women that were treated with Premarin and Provera compared to the placebo group.
You mean among the women with lots of hot flashes? Is that what you mean? So this was a post hoc analysis of the WHI, which overall results from the WHI showed increased risk for cardiovascular disease events with hormone therapy, particularly among the older women, 60 plus, I believe. And then there was another post hoc analysis that showed an interaction with vasomotor symptom status, that it was particularly pronounced among the women, the older women, again, so this is 60 plus, who have vasomotor symptoms, moderate to severe vasomotor symptoms. I would interpret that as indicating that these women have more underlying atherosclerosis, plaque, and you could potentially lead to plaque instability with hormone therapy. But again, we don't know necessarily the underlying mechanism, and also proceed and interpret the results with caution, because this is a post hoc, two-way interaction. But it was also observed in the HERS study, which is our post-MI trial way back in 1998. Of women who had established cardiovascular disease who were randomized hormone therapy. There was also interactions with vasomotor symptom status in that trial as well. But again, a post hoc analysis interpret with caution.
If I may add something, we have also to look at the picture the other way around, because we know that women, they are younger in the transition, and they take hormone replacement therapy for in that particular window, they can gain some benefits in terms of cardiovascular health. And we may assume that women, they are taking hormone during the transition is because they have the motivation of hot flashes. But of course, this does not mean that we may use hormone therapy to prevent cardiovascular risk, but it's a signal that reinforces the idea that when the vessels are healthy, when you have the hot flashes, but you still not so compromised in terms of your cardiovascular risk, you may gain some benefits when you are young. And this is particularly true in women that enter menopause early.
Okay, another question. The issue of cardiovascular disease and brain deterioration is more related to the symptomatic woman than one with no or minimal symptoms. Is this true also for non-MHT versus menopausal hormone therapy users? And do we have any information yet?
I believe this one's our data as well. We excluded women who are using hormone therapy simply because we won't be able to observe their hot flashes. So we don't know with the dementia and brain-related outcomes in terms of the way that the vasomotor symptoms are related to those neurocognitive outcomes, whether that varies according to women taking hormone therapy or not. We don't know that yet. But I will, and all of our studies on hot flashes and neurocognitive risk have largely been performed among women not taking hormone therapy.
So would be interested to see, to do a test with the women who are on neurokinin B receptors, antagonists, to see if you also see the benefits.
There's been a hypothesis out there that a number of people have talked about, that vasomotor symptoms may be an indicator that vessels are healthy and that the endothelial function, their reactivity is present, that when plaquing develops, that endothelial function is gone and you lose the ability for vasodilation and the manifestation of a hot flash. On the other hand, there's data showing that hot flashes increase the risk of cardiovascular disease. How do we adjudicate those two thoughts? Is it possible?
Well, yes, I can tell you about our data from SWAN that actually showed the women with more vasomotor symptoms had poor endothelial function. So their vessels were less responsive to that shear stress on the vessel wall, which leads to vasodilation. That's an endothelial mediated process. That's one of our ultrasound related tests that we do for endothelial dysfunction. The women with more vasomotor symptoms had less vasodilation in at least the brachial artery. So what you're seeing with that flushing is in the small vessels on the skin. Those are a little bit different than the larger vessels that we're oftentimes testing. with respect to the vascular endothelium and the brachial artery and the coronary arteries. So just to not get, just to clarify that point, that it actually is poor endothelial function with those women.
In light of your findings that estradiol levels do not explain vascular reactivity or increases in carotid IMT, what other factors are related to these phenomena?
Yeah, so that's the part of the talk I kind of breezed through at the end. So we do not see that the relationships between the vasomotor symptoms and the cardiovascular indicators are explained. They're not explained by our endogenous estradiol levels. There's a number of different mechanisms that we haven't fully figured out which it is, but we've looked at greater circulating inflammation, poor autonomic nervous system balance, as well as alterations in the hypothalamic pituitary adrenal axis and some epigenetic aging mechanisms. Those are the four that are we've looked at, we've been looking at, that may be alone or in combination contributing to this.
So there's a comment that some women do not respond well to hormonal therapy regimens. That it seems that they don't absorb the hormonal therapy, maximum doses, different preparations, and so forth. The question is there data showing the percentage of women in this situation? How common is this?
My experience, yes, of course, as any drug we use, we have a certain amount of non-responder that can move from 10 to 20%. But I would like to remind to everybody that there are many risk factors for not responding to hormones in women. And the first is drinking alcohol, smoking cigarettes, being overweight and not exercising enough, having a certain kind of personality, and so on. So we don't have always to attribute to plasma level in the circulation an effect. And so, of course, we can increase the dose and see how it looks. For example, in our experience, women with surgical menopause, they may suffer more from hot flashes. They do not respond to estrogen, so because they need probably higher dose, or even as it was thought in the past, a supplementation with a little dose of androgen. You know, the question is really open, but we really need to consider the full story and many other risk factors. And sometimes you stop using spicy food, and immediately after, women, they feel better.
Any evidence for metabolic side effects of levonorgestrel absorbed via patch? Is it similar to the effects from OCPs?
We don't have a signal that transdermal levonorgestrel has a strong impact or stronger than other compounds on the liver. This is, we didn't accumulate so much experience because, as I told you, that was a patch that is still used in Europe, but not so widely. But the data we have from the trial and from our clinical experience do not support a detrimental effect. Of course, you use this progestin transdermal. My experience, we use a lot in women. We really need to stabilize them. They are intolerant to the oral use of progestogen due to PMS, migraine, etc. And when we use low dose, we can achieve a stable level and a good balance between amelioration of hot flashes and other aspects of general well-being.
So, there's a question about whether if you can make a comment on the countries that don't check liver enzymes for patients on fezolinetant and why they are able to do that. They said that I'm so excited for this drug to come to Canada. I'm an oncologist and many of my patients cannot have estrogen, but I worry this could be problematic. I have memories of fibrostol being removed for liver issues, and that was an excellent medication.
Okay, so the question is why there are so many why there's a difference between regulations?
Yeah, so which countries do not require it and why?
I only know that the European agency does not require liver enzyme checks. And so I would guess this applies to all European countries. And yes, I also think it's surprising because all of the regulatory authorities have the same studies, but they seem to decide differently. So in the US, it's very strict and you have to check the liver enzyme several times after you have started on the treatment. And in Switzerland, we only need it before treatment and then after 3 months, and then we are done.
Great.
So a few more questions about fezolinetant. Can you use it in women with breast cancer? And are there any cognitive risks?
So officially, it has not been studied in breast cancer patients yet. So this is why there's always kind of warning in the insert of the packages. However, I think all of us are waiting for the study to start in breast cancer patients so that we feel better if we prescribe it. And for cognitive function, this has not been assessed specifically in the studies that led to approval. However, there were no special cognitive impairments documented as adverse events. So which means for now, I would say there's no negative or positive impact, but probably we have to wait for more studies again.
We want to thank everybody for their tuning in and being a part of this wonderful presentation. Dr. Wolfman, would you like to wrap us up?
Yeah, I'd like to thank our speakers and all the people who are still online. And we're going to just show you a little bit about our affiliated menopause societies. And we'll go to the next slide. Being a member of the International Menopause Society, there are some exclusive offers. There's free 1-year IMS membership if you complete IMPART Level 1. We also have the partnerships with local and regional societies who are members of the Council of Affiliated Menopause Societies. We have these monthly live events, an extensive library of educational resources. Joining IMS is fantastic. And we have our meeting in Melbourne between the 19th to 22nd of October. And I hope we'll all see you then. And I thank you very much.
Bye-bye.
Thank you, everybody. Thank you, everyone, for tuning in.
Thanks, everybody. Thanks to the speakers especially. It was a great webinar.